We have about 15, 20 minutes for questions. Anybody that has questions can come up to the microphones.
I have two questions. One's for Jay first. Concierge medicine is permissible. You can have a high deductible insurance plan and use a concierge doctor the traditional way. It's okay. If you're a patient and you decide that you wanted a DPC doctor and you have the traditional high deductible plan, you have an insurance plan, it's not legal to use that doctor and not put in any claims into the insurance model?
You can use that doctor, but you can't receive a benefit.
A tax benefit.
Yes.
Okay, so when you're talking to employers, that's the distinction. But as an individual, if you can convince individuals to do that, which would be better for them.
And they'd be doing that with after-tax dollars, and so that's where it...
After-tax dollars, but saving a bundle by not putting it through their deductible.
Correct. Yeah.
Okay.
Yeah, absolutely.
So that's the distinction that I just wanted to make sure that I understood. And I have a question for Lee. Lee, have you or anybody yet solved the issue about immunizations in children?
No.
Okay, thank you.
Okay, so my question is, utilizing DPC under a cafeteria plan or a Section 125, bundling it with like a Colonial Life or an Aflac, because it's not very specific in the language. It just says health services or health care. And so my question is, do you guys know if that's allowed or not?
Yeah, I was reading up on that earlier this morning, actually on DPC Frontier, and they say it's foggy. It's foggy. Yeah, I mean, DPC Frontier is a great resource for all of this stuff. You know, I do believe that that 213, Section 213, where it lists, I mean, I think that also applies to the Section 125 plans.
Yeah. I know,
I'm
it's
sorry,
fine.
I can't give you a grade.
I mean, our accountants are doing that in our community, and they're, you know, that's from the accountant, so it's kind of on them. But I was just wondering what your thoughts were on that. So.
Yeah. Well, sorry. Not anything more than what I said before. The problem is you were trying to make sense out of something that's kind of nonsensical, because again, the regs were all written before any of this stuff that we were talking about was invented, and that's the problem.
Okay, thanks.
Mm-hmm.
Dr. Haynes?
Yeah, I'm in spite of Hal's great question, I'm still confused about this HSA thing. So I have a high deductible health plan, I have an HSA, and as long as I pay non-tax, then I can still do DPC and not run it through the HSA.
Correct.
Or if I do it, because the way you described it, it sounded like there was no way for me to pay a DPC without disqualifying my ability to put money in the HSA.
If you want to pay for it out of your pocket with after-tax dollars, and the DPC does not go towards your high deductible, it's just basically off plan, off books with after-tax dollars, you're okay.
That's great. So then my other question is for the group, if there's a DPC doctor in Nashville, I have my daughter for you. Come see me.
Go ahead.
Yeah, I have a question for Jay. It's following along the same issue. But if an employer wants to provide this benefit for DPC pre or after tax to his employees, does that mean that his health insurance won't qualify under the ACA?
Okay, run that by me one more time.
So
we're talking about small employer with a plan or not without a plan?
Well, I don't know. But you were talking about how you have to do, if you're going to provide the DPC as a I guess it would be with a plan, you're going to provide the DPC as a pre-tax benefit. Sorry, I'm losing my train of thought. But you said you could run into problems with it, access versus care. But if you do it as a after-tax benefit, does it still qualify as ACA qualified primary
If it's
care?
after tax dollars and the employer is helping, then I mean, it's taxable income, we're fine.
So it's not a tax issue and it still qualifies as primary care for under the ACA?
It's just compensation.
Okay, all right.
I mean, so far, there's not any laws against what you can pay somebody, so, yeah, if the employer wants to just give you a raise and you can use it to go buy a new TV or a DPC membership with it, it's just compensation at that point.
They can't specify what you have to pay the money, or use the money on.
Right.
Dr. Eskew?
So what I just said is they can't specify what you spend that money on. They can't require that this raise is for DPC. They can say, you're getting a raise and we hope you use it for DPC, but they can't stipulate it.
So I wanted to provide a clarification if I could. As far as the non-compliant plan discussion, it's always confusing. It's gotten easier though. So what was mentioned up there, the $100 per day per employee fine, that really isn't going to happen much now. That was changed with the Cures Act, which was passed in December 2016, I believe. So if you go to section 18001 of the Cures Act, which I've got cited on DPC Frontier, there are 3 areas under there where they've got a new broad exception that largely swallows the rule for HRA issues. So it used to be we had this weird situation where to be deductible for section 213D, we were arguing that we were a medical expense. Oddly enough, with that old $100 per day fine, which is technically still on the books, but not really, which I'm trying to explain, if you're not a medical expense, which the IRS currently takes the position that we're not, then that $100 per day fine doesn't apply in the first place. We like to argue we are a medical expense, in which case we need to be under this new large exception that swallows the rule. How do you get in that? There's basically 3 things. 1, it's funded solely by the employer. 2, you are indeed a 213D medical expense. And 3, per individual, you're $4,950 or less per year, or per family, you're $10,000 or less per year. So when it comes to the small employers, the less than 50 that were really worried about offering DPC, my broad comment is one way or another, you're out from under that $100 per day fine. It's not an issue if they do their homework.
That is a great update. Thank you so much.
And could you send us that information? Send me a link to where that is so I can get it out to membership.
And if anybody doesn't know, that was Dr. Phil Eskew, the proprietor of DPC Frontier.
I think you're up next.
Thank you, gentlemen. This question's for Jay. Can you mention briefly about flexible spending account? How would that work in terms of DPC, since FSA is an employee contribution pre-tax?
Phil? I knew I was going to get that question. I was on your website this morning, and you guys kind of said it was foggy.
Phil, if we're completely stealing your thunder for your presentation, you can just say we're going to cover it in your presentation, and
Yeah, that's probably easier.
why don't we do that? Why don't we go ahead and defer that to the legal panel, so we're not duplicating that.
Yeah. So
Thanks.
all of the health savings account, flexible spending account, et cetera, questions, he will cover this afternoon.
Yeah.
So.
I have a question for Jay. You mentioned that as a self-insured entity, having DPC under your HRA, your physicians or your employees' physicians document for you monthly that they're receiving care. What's the most efficient way to accomplish that?
Yeah, that's a great. I was actually having dinner with a DPC out of East Texas, Dr. Smith, and he is actually providing basically a claims feed back to the TPA. I think he's doing it through, Jeremy, are you in the audience? Yeah. You want to kind of address how you're doing it? Because we're not doing it with you yet.
Any chance you can step up to the microphone so we can record their answer?
We're providing a data feed back to our employers to show utilization, but one of the benefits is we can prove up that we're constantly managing care. We're currently doing it through our app that we reach out and touch patients with. They're outside. Their name is Spruce. We've worked with them all year on the importance of having that data automatically, not extra work for the doctor, come into the medical chart so that we can mine that data and get it back either to the TPA, hopefully that knows how to interpret that, or the employer when requested. So you want to automatically set that up. You don't want your doctors out there having to do extra legwork. So that's how we're currently doing that.
And that would be the way to go. What we're doing right now with our employees is they're just bringing in whatever they get from their DPC, and it creates an additional workload on the DPC. So an automatic feed would be great.
So, and we're not holding this panel by saying that everyone here should be working with businesses and that should be your ultimate goal to grow your DPC with businesses, because some people sort of see this as getting right back into the third-party interference and slippery slope, and aren't we just getting ourselves into the same situation we sort of extracted ourselves from? So what we're trying to do is give you a broad view of what's possible and the pitfalls and precautions you need to take if you do choose to go in that direction. But we're not necessarily saying that we think that's necessarily the right way to go, but considering that the majority of healthcare in the country is employer-sponsored, as much as we'd like to bust that model open, we still have to deal with the realities of that.
Yeah, I mean, the way I explain it, even though it's my business, I mean, there is a gravity well that is pulling, that wants everybody to come back to the status quo. And I would hate for a DPC practice to ever say, well, I've got to get that volume, and so I'm going to work with this 600 life employer, and I'm going to work with their TPA, and their TPA happens to be an insurance carrier, and next thing you know, you wake up a year later and wait a minute, this doesn't feel like DPC anymore. It's going to be easy to get back to that, so it's going to take some discipline.
A question for Lee about specialty care. Where I am, I'm in Grand Rapids, Michigan, and mostly they are all within hospitals. But let's say the few that are independent, when you call them, you talk to a manager, not really to the doctor. So how do you approach, when you're talking to the manager, for them to give you better prices than the insurance rate? Because what I find when you say cash price, all they do is they grab the insurance rate and have the patient pay that, or maybe they discount like 10% off the insurance rate, which is still, it's an totally unreasonable price.
Yeah, I think if you can get the price on paper, it's already a win. I mean, it's a starting point. I mean, because you're starting with just fantasy numbers. So at least if somebody's willing to put it on paper, I think then you can at least begin a conversation. A lot of the challenges we get is, I'll have a patient that has Blue Cross insurance. I'm not picking on Blue Cross. You can insert any insurance company in there. And I'll say, we're going to go ahead and send you for a CAT scan. Well, how much is that going to cost? Well, I don't know. Are you going to use your insurance? Yes. I don't know. And I could call up the imaging center and I'd say, I have a patient with XYZ insurance. How much is a CAT scan? They're going to say, I don't know. And it's not that there's no way to know. I mean, it's almost impossible. So to have something where you actually get a hard number on a sheet of paper is a major accomplishment. Even if it's not a price you like, at least we can look at it and say, okay, well, now we know what it is. Now we can deal with it. And then as you build a relationship, you can start working on getting that number better.
You are right, though. There are hospitals that I look at as if they punish cash. Cash gets the charge master. Charge gets 5% off the charge master, and it's ridiculous. And that's actually one of the FMMA pillars, that cash should be king. Cash on the barrelhead should bring the best price. If you're not able to pay right then, point of sale, then the negotiation starts there. How long is it going to take for you to pay me? Am I going to get paid $100 dollars? Am I going to have to chase some fraction of the payment? But in our world, if a hospital is going to punish cash, then that tells us that might not be a great partner for us to be talking to.
Well, and I wanted to point out as well, that's one thing that the Free Market Medical Association actually helps do, is if you guys need a cash price for a specialist or imaging or a facility, you can look on our website, you can call us. You can also reach out to the local chapter in your area. We do have a chapter in Michigan. I know that Chris has helped, some folks a ton of times for us find cash pricing in their areas. So feel free to use us and our local chapters as a resource for that as well.
Can I just say one thing? You know, since we're talking about trying to connect buyers and sellers here, is there anybody in this room that is looking to hire a DPC doctor? Show of hands. Okay. Anybody looking to be hired as a DPC doctor? You guys need to talk to each other.
Well, and also we have a free market medical jobs portal on our website where members can post jobs for free and anyone can apply for free. So you guys can check it out and post your jobs. Go ahead.
Okay, I'm Dr. Melissa Black, second-year direct primary care in Atlanta, Georgia. I have two quick additional questions about the integrated HRA requirements. One was the documentation. How much care is an annual physical adequate for the year for the monthly charge in terms of documentation, or does there actually have to be monthly interaction? And second, when I create my membership, what I call now my membership agreement, should I rephrase that as a care agreement? Should I not use the word membership because I'm providing care, not?
I like the way you think. Yeah, a lot of this stuff is optics. And that's why we caution you, don't call yourself concierge. I mean, even though it may connotate kind of what we view ourselves as, well, somebody's already bid us to the punch. Somebody else, another business model uses that word, and we don't want to be associated with that business model. So when you're talking about, should I rephrase my agreement to say a care agreement versus a membership agreement? Yeah, I would definitely recommend that. It just gets you further away when you're having to make that argument if you were ever under some sort of an audit. Back on the documentation, this documentation question, it's fuzzy as well. You know, again, these are nebulous times right now. Hopefully the regs will get straightened out. But we do feel like if you can document that it doesn't have to be monthly. If somebody goes in for an annual physical, risk assessment, et cetera, our opinion is that would suffice. But we are not giving you legal or tax advice right now.
So we just changed our receipts, the wording on our receipts, and it used to say DPC dues, and now we changed it to DPC services. Just the optics of it.
Much better.
I think you were next.
Other than Health Sharing Ministries, do you have any other suggestions on helping patients find catastrophic health insurance coverage?
We really don't. I mean, you know, the Affordable Care Act, you know, mandates how high a deductible can be, and they mandate all the additional coverage within, so it's hard to have a stripped down plan that dovetails perfectly with direct primary care.
Yeah, I mean, there are plans out there, but they're not going to be ACA compliant. Mm-hmm. They're going to exclude for pre-existing conditions. They're going to rate you, and so you're going to pay more if you're sick, or flat out deny you. These short-term medical plans that now that if this executive order is carried out, or that short-term medical plan can be extended from 3 months to a year, which is I think what their intention is. Even at the end of the year, let's just say you get cancer within that year and you can come up on your renewal, at the end of your year, you're not getting renewed. Right. So if you get cancer in month 11 of your 12-month short-term medical plan, you're uninsured at month 12.
Go ahead.
In terms of negotiating with surgery centers for transparent pricing and things like that, as a physician, there are regulations with, and I know many of us are trying to get out of the whole insurance thing, but with Medicare versus insurance, we have to be careful about different sorts of price schedules. Is there anything like that surgery centers and diagnostic centers have to deal with if they give us a cash, kind of a cash is king price schedule versus what they're going to charge insurance companies or Medicare?
Sure. So we have one singular charge master, and everything is going to be a discount off of that. Essentially, what you're getting off of our charge master is a self-pay discounted price. Where it's changed a little bit for us is now we are offering we had to essentially create and make up a bundled charge that would be an all-inclusive bundled charge rate for that. And then there still is a discount off of that. Honestly, a lot of that comes from you still do have TPAs that are out there that want to show savings. They want to show that, hey, look, by working with us, the employers, by working with us, we're still giving you a savings off of something. So they want to see a charge, but we just essentially applied the procedure codes to a new charge master that was for all inclusive bundled rates. But we keep one charge master.
Chris, are you allowed to undercut Medicare? Can you charge?
I do not undercut Medicare. We do take federal dollars, and we've never gone below the Medicare rate. And honestly, as speaking as an administrator, Medicare doesn't pay us enough. So if I were to actually want to undercut Medicare in terms of trying to get volume, there's no amount of volume that will help me if I'm losing money on every case. So you really don't want to do that anyways.
I feel your pain.
Yeah.
And I may add to Chris's comment about some TPAs and some insurance companies that want to show a discount. It's not just that they want to show that they've saved you money. It's worse than that. A lot of those folks will also charge the employers a percentage of the deal that they cut for them. They charge a percentage of the discount. So they want the hospital to charge monopoly money prices so they can show a big discount and then send a bill to the employer for 20% of the discount that their sweet negotiating provided. So that gets back to one of the FMMA pillars, is the bundled cash pricing for all, cash price equity, is to fight against that. Pricing should not be a commodity. Care is something that we buy and sell, but there's this arbitrage out there it's evil.
You were waiting first?
Yeah. So I'm out in Jackson, Wyoming, which is quite rural, and we're dominated by healthcare systems. I had a patient and this is about working with specialists, and a patient with a busted knee needs an MRI. I call around and get from the $1,500 horrible price. 2 hours away, there's an HCA hospital that'll give an uninsured patient a $300 MRI. So my question is there anything that I need to be careful on about advising my patient, listen, they'll do your $300 MRI if you tell them you're uninsured?
I think this is probably something that Phil's going to get in, but that's probably where that HITECH Act comes into play, and they actually have to sign they have to sign that the plan's not going to disclose or they're not going to disclose your personal health information to your plan. So it's not necessarily that you have to lie to them. Right. You just basically have to sign a waiver. Okay. And I think Phil's going to address this. Cool.
Even with that being said, though, we have seen, because obviously we encourage that a lot at our company, we have seen medical providers that if they do find out that, oh, lo and behold, you have insurance or they have a network contract, they will try to crawfish and send a bill.
Dr. Corwith?
Yes, hi. Thank you very much. I'm on a Facebook feed right now. There's a lot of people watching. And there was a question, and it's a general question. If you could just help us, help me provide them with the proper information. Everybody's asking how we get in contact with, or a DPC practice gets in contact with a broker that it follows the pillars of FMMA in their state.
Well, you can call us. Our phone number is 1-866-901-FMMA. If you're a member, you can actually view all of the other members by logging in on our website. There are not as many brokers as we would hope, that actually follow this model, because many of them are also compensated based on the percentage of savings and things of that nature. And the FMMA does do reviews of anyone that is not a buyer or seller. If they're a TPA or broker, they have to go through a review process. You can check out our website at fmma.org. If you're, like I said, if you're a member, you can log in and view all the other memberships. And if you have a specific question, give us a call. Dr. Davenport?
Pretty exciting that a lot of people are watching online, even that aren't even here. But one of the other questions, and I asked this at FMMA, probably directed at Jay being the TPA on the board. how do the direct primary care doctors get the TPAs who are actually the good guys, you know, the good hats that we talk about, to involve the DPC doctors in approaching the businesses? You know, from our perspective, it's not an easy thing to get in to see the owner and the CFO and the CEO. At best, sometimes we just get in with the, you know, the benefits person or whatever, and they don't really see the big picture a lot of times. And so how can we get the good guys who are members of the FMMA to really involve us in approaching the businesses? Certainly one thing that I've learned is I don't understand the numbers side of thing, and everything you just gave your talk on. I know there was probably a bunch of people in the room who are lost in that conversation, to which I would say, join the FMMA, keep hearing that talk over and over and over again, and you'll be where I am 4 years later. I know what an HSA is finally. But we're confused by the numbers side of thing, but I believe that you know, the CEO, the CFO, the owner that makes the decisions for those companies, you understand, or I mean, you explain all of the you know, the legal documents and all the number stuff of it, but no one can sell direct primary care like we can.
Yeah, I was going to say, you know, Dr. Davenport, you and I have we've had some wins together. Dr. Smith was sharing with me last night that he had some wins, and you know, this is not right now at this stage of the game. I think that the best salesperson for direct primary care are you all, and if you can have that conversation, not with somebody like me, but have that conversation with a business owner, the CFO or the CEO. Do not waste your time with HR. I hope that changes, but right now all they know is what their Blue Cross agent told them to know. But if you can start that conversation as high up the food chain as you can get and convince them of your value proposition, which is easy to do. What you all do, it's the most sane thing going in healthcare. If you can get them to understand this at a fundamental level, they will bring the parties that need to be involved, they'll get them involved. They will call their agent, and you don't want them calling their agent or their TPA and saying, hey, what do you think of this? You want them calling their TPA and saying, hey, I want to do this. Make this happen for me. And you all can do that. If there's a TPA that's a friendly, independent TPA that you know, you see at Rotary or whatever, it's probably worth talking to them. But we're very, very busy. I'm probably one of the unique TPAs that I'm kind of like you guys. I'm small, I'm independent, I'm ornery. This is right up my alley, but a lot of even good guy TPAs, they're very, very busy. They have a lot of network contracts, and this is way, way, way outside their box. They may be willing to do it, but if they hear it from a client, that's how it's going to get done quicker.
It looks like we're actually out of time. I want to thank these gentlemen for doing a fantastic job.